Welcome to my world, the world of a medical laboratory scientist. Health is wealth, knowledge is power. Acute jaundice and kernicterus. When a baby is born, the usual practice is to probably look at their eyes and see whether they have no jaundice, especially preterm babies. Because from day one, that jaundice is a reflection of the breakdown of red blood cells. When these red blood cells are broken down, they are broken down into heme and the hemoglobin. The heme and the globin separates. The heme is further broken down to bilirubin, and it's that bilirubin that is not mixable with water. That's why it's called unconjugated bilirubin. Now moves, but inside the liver, the baby's liver is still very immature, but it does the work okay, and then the excretion would usually take away this conjugated bilirubin. But when the conjugated bilirubin or unconjugated bilirubin especially is now accumulating, that is when you now see those yellow color on the eye and on the nails and co, which shows very clearly that the baby is jaundiced. But the truth about this jaundice is that if care is not taken quickly, it will now move into the brain, where it will cause this problem called kernicterus. Kernicterus is now a situation of where the unconjugated bilirubin moves into the brain and color the brain. The blood-brain barrier would not allow the conjugated bilirubin to move it, but the unconjugated, because it's fast soluble, it could easily penetrate the blood-brain barrier and then color the brain. Affects it, it damages the brain, causing serious brain damage. The complications are so many, which I shall exhibit in the slide session very well for us to understand. When we are now concerned is, what are we expected to do immediately that there is that discovery of jaundice? There are probably other underlying reasons that is causing that hemolysis. It could be as a result of the rhesus incompatibility of the mother. It could be even the ABO incompatibility. It could even be G6+, anything that could cause the breaking down of the red blood cells, which is called hemolysis, is what will produce this jaundice, this unconjugated bilirubin. And once the baby, as a baby, is not well developed to be able to take care of all those massive bilirubin, then you now find it affecting the brain of the baby. If care is not taken and is not quickly treated by the appropriate health professional, it will become a permanent damage or even cause death of the baby. But majority of time, we just notice jaundice and we don't know the implication of what we have said with such a child. The medical laboratory scientist plays a very vital role in being able to measure the bilirubin. When the bilirubin is more than a certain value, threshold value, then it is reported, and immediately more emphasis is placed on the cause, to find the cause, treat the cause, and reduce the hemolysis. And also, apart from phototherapy, where the child is placed under this blue light to make sure that the jaundice clears, and that is what is monitored for a very long time. Adult school could have it, but it is very common with children. The medical laboratory scientist's role is just to check also the underlying factors, whether there could be other things causing it. They may have to do the Coombs test, they may have to do Jesus PD, or even if it is the breast milk toxicity. There are so many things that could result in hemolysis, and that is what I shall expose more in the slide session. So if you like my presentation, press the like button and subscribe. The outline, objective, introduction, the cause or the risk factors, laboratory diagnosis and treatment. The objective, to create more awareness of kernicterus as a chronic jaundice problem with a serious neurological disorder, as opposed to the common acute jaundice, hyperbilirubinamia, the implications, laboratory diagnosis, and treatment. The introduction. Acute jaundice is more or less neonatal jaundice that is extremely common, affecting roughly 60% of term newborns and up to 80% of preterm infants during their first week of the baby. While most cases are mild and resolving on their own, about 10% to 15% requires clinical monitoring or treatment, and higher burdens outcome in developing regions of the world, that is economically challenged countries. Bilirubin is the byproduct of red blood cells destruction or degradation, which naturally occurs after 120 days, the lifespan of red blood cells. The heme part of the hemoglobin content is what is further broken down to unconjugated bilirubin that appears as yellow all over the baby's body, and that is the jaundice. When the heme is attached to the albumin and taken to the liver will conjugate it and make it excretable. It's now excreted in the as feces, brown color, or in urine, sometimes with the amber or whatever color that we see. Laboratory investigation of hemolysis, the breakdown of the red blood cells by extraneous factors, would confirm the cause, which overwhelmingly resulted in the jaundice. That is to say that if it is G6PD deficiencies, you could, if it is RH incompatibility, you could then confirm and then know what to do. As the liver couldn't conjugate them, the population, the quantity, the quantum number of this unconjugated bilirubin is more, overwhelms the liver. The baby's liver is still immature and not as effective, and so the conjugated bilirubin would find its way to the brain, and they penetrate the blood-brain barrier, causing neurological disorder, kernicterus, that is the bilirubin, hyperbilirubinemia, encephalopathy, and death could also result if not treated. You may be wondering what's the cause, what are the things implicated in this jaundice situation of these neonates or people who have it. Preterm, when the baby is a premature baby, the blood incompatibility, which are the earlier explained, ABO or rhesus incompatibility, you are now talking of trauma, birth trauma. Could also, then the G6PD deficiency, those who have it will always have the problem of hemolysis. The red blood cells easily breaks, causing prematurely. It breaks before the lifespan of the red cells, and the quantum number becomes a problem for the liver. So you have more of unconjugated bilirubin in the body, in the bloodstream. Family history: a prior sibling who requires that severe hyperbilirubinemia under 2% progress to degenerative level, a dangerous level with higher regional impact reported in sub-Saharan Africa and Southeast Asia. Furthermore, kernicterus is divided into three main types. They have the acute bilirubin encephalopathy, which is at the early stage. It has penetrated the brain. Before it could call it kernicterus, it must have penetrated the brain, and then it could cause this multiple neurological dysfunction, including hypotoma of hypertoma, lethargy, fever, seizure, etc. Epilepsy. Death can result in severe cases. Then the two is the subtle bilirubin encephalopathy, and the third one is the chronic bilirubin encephalopathy, when it has become permanent over a year and untreated. The complications are many: epilepsy, deafness, vision problems, and co, because these are all in the brain. The brain interprets so many things, so that could affect the growth of the baby, the infant that is growing. Laboratory diagnosis. Early diagnosis and interventions are crucial to prevent the progression of jaundice to kernicterus, and that I have emphasized more. So blood tests are performed to measure the level of bilirubin, both the direct and indirect, and the total. Then the elevated, once the result shows the elevated unconjugated bilirubin level, then there is that need to start whatever necessary treatment that can be done. The blood type, mother and infant, when you want to really know the cause, could also be done. Coombs test helps in the assessment of the RH incompatibility. Reticulocyte count can also be done. There are so many assessments, even the CBC, complete blood count, and the peripheral blood, the appearance is also very descriptive of or indicative of that jaundice situation. Finally, treatment. Early detection and intervention are key to preventing the progression of jaundice to kernicterus, and that is very, very important. And what do we do? The usual thing is to check the skin, check the eye, look for how to then remove it by putting the baby under the blue light, especially the preterm children. The cubicle where they are, they have this light focus on them. Then where it is not going and the level of the bilirubin is so high, then there is the need to do exchange blood transfusion, which will rapidly bring down the bilirubin level. There are other things that can be done as far as cause is concerned, the cause of that problem. And there are other problems, health challenges, conditions, syndromes that present with all these high bilirubin level. Like I've always been saying, there are many videos in this channel on health and the role of the medical laboratory scientists, how effective the medical laboratory scientists are. So you can watch more and encourage more production. Thank you.